Good afternoon, or evening, or morning, or whenever it is that you might be listening to this episode. This is the last ish episode. I think it's the last episode for the GI system. Thank goodness. I've decided I'm over this section and I am ready to move on to cardiology. But before we can do that, we have to go through GI procedures, which also includes two, I guess it's like some diagnostic procedures as well as two surgical procedures. So it's kind of interesting. It's not truly like a diagnostic section, and these are considered procedures, but they can be diagnostic, they can be therapeutic, all very relevant for your surgery rotation. So I like that they picked these topics, but still kind of interesting because they picked these instead of some other ones, which I don't think is a bad thing. It helps me because they didn't pick everything they could have, which is a lot. So this episode will probably still be long regardless of all that. Anyways, this episode is GI procedures. I am so looking forward to being done with this, and let's get started. First off, let's go ahead and talk about our study tip for the day, which I wanted to talk about note taking. I am a big believer that everybody is going to take notes differently and they are going to work differently for different people, and no one person's notes are going to look the same, nor should they. Personally, I had to figure out how to take notes in PA school because I couldn't do what I did in undergrad there because the amount or volume of information we got was just so much that I honestly could not type on a Google document or a Word document and keep up with what everybody was saying. So instead, I ended up having to, if I could, create an outline on a Google document before I went to class based on the PowerPoint, or I would use the PowerPoint, jot down my notes, and then after class, write a Google document. And the specifics of how I write my notes, I think I can get into on another day, but there are people who really like to just use the PowerPoints and their little jots, and then they would just use the PowerPoints to study and talk through. And then there were people like me who really wanted to have things written down in a different way. And then, even still, there were other people who, instead of doing matrices or outlines, which I love, they did a Cornell method, or they would draw pictures and create little stories. Actually had somebody in my cohort who did that, I think. I can't do that because I'm not artistic enough, but I love organization and I love outlines. So for me, if it was something that made sense to have an outline, I did that. With all these conditions, a lot of the things are the same. You're always going to be doing diagnostics, you're always going to be doing presentation, you're always going to be doing treatment or management or patient education. So it gets repetitive. So I honestly made a template outline where I had procedure in the top and then the sections that I wanted on the left hand side, and then a special way that I like to have my bullet points. That way, I could just make a copy of that document over and over for every class and just plug and chug information in, which worked for me because then my notes were already made. So I didn't have to spend time outside of class making them. I was able to keep up when I did it this way. Let me know what kind of note taking you do in PA school or grad school or even undergrad that maybe is different than what I did. Because again, I think everybody does notes differently and they look different, and we all need to get the same information. So, more ideas, the better. Let's go ahead and get started with our GI procedures for today. First up is endoscopy. So, this is really, I tried to focus on EGD versus colonoscopy versus sigmoidoscopy. Those are all different types of oscopies. This first one, I'm kind of just focusing on EGD, and then I'll talk about colonoscopies. Regardless, the purpose is to visualize the lumen of the GI tract from the esophagus all the way down through the ileum and colon, depending on whether or not you're doing a colonoscopy versus an EGD. An EGD stands for esophagogastroduodenoscopy, or an upper endoscopy. There are some indications for this. They are diagnostic and therapeutic. Diagnostically, this is for an evaluation of patients with dysphagia, weight loss, upper abdominal pain, possible varices, dyspepsia, or a suspicious barium study. Also, for evaluation of possible upper GI tract symptoms. And then therapeutically, these indications include things like taking an excisional biopsy, injecting sclerosing agents, dilating a stricture, or placing a stent. Now, the contraindications for this are patients who have a severe upper GI bleed where you're not able to compensate, diverticula or a suspected perforation of the GI tract, a recent surgical repair, and toxic megacolon because the dilation is so large that it increases your risk of perforation. Now, complication-wise, the biggest complications are things such as respiratory depression from the sedation that you use, aspiration risk, perforation of bowel, which is very rare but can happen, bleeding from injury or biopsy sites, and then dehydration. Different things that you can see are tumors, diverticulitis, polyps, strictures, different areas of bleeding, varices, hiatal hernias, evidence of peptic ulcer disease, things of that nature. The actual procedure for an EGD is essentially it's a long, flexible fiber optic scope through the mouth. Your patient needs to be NPO for around 8 to 12 hours ideally, and this is done under very light anesthesia. The scope is passed through the oropharynx, the esophagus, the stomach, and the duodenum, which is about where that ends. The air is insufflated through the EGD to distend the upper GI tract for visualization. And then the person doing the procedure can do an inspection, just look around, biopsy, or perform other various treatments. Essentially, it takes around 20 to 30 minutes depending on what is being done and the severity of the situation, but it can be mildly uncomfortable after the procedure. You can have some gas pains from all the insufflation that you did. However, overall, it's a really great procedure for the situations that you kind of really need them. So when you need them, you really need them, and they're really helpful. Pivoting just slightly to a colonoscopy, again, this is a diagnostic and therapeutic oscopy, so fiber optic scope to visualize and do something about what you see. This one also has some screening indications. So, diagnostic indications include patients with a change in bowel habits, including blood and stool, abdominal pain of unknown origin, and no history of colonoscopy or an abnormal sigmoidoscopy. Therapeutic indications are excisional biopsies, polypectomy or removal of polyps, or stricture dilation. You can also do treatment of bleeding vessels. Screening indications. So, this is used for screening of colorectal cancer and following up evaluations of colorectal cancer, IBD, polyps, or diverticulitis. Complications, very similar to what I mentioned right above. So, it's all the same. Aspiration risk, perforation, well, not really aspiration risk for this one, perforation risk of bowel, bleeding from injury or biopsy sites, dehydration, abdominal pain, all of that good stuff. Now, what's next? The procedure for this, very similar idea, long flexible scope. Ideally, patients are NPO, very light anesthesia is used. The scope this time is passed through the anus, rectum, sigmoid, descending, transverse, and ascending colon. Air is again insufflated to visualize the lower tract, and you can do look arounds, biopsy, or other various treatments. So that's your oscopies. I think that's really all you need to know about these. The major complications, the very big and large indications, and just very briefly, sort of what the procedure is. There's plenty more details that can go into that, but generally speaking, I think that'll get you through. Next up is NG tubes, which I think maybe I talked about in the small bowel obstruction section. I'm honestly not super duper sure. There's so much you can talk about with NG tubes. I manage these every single day. They're very, very important in the surgical world. And we'll just go ahead and get right into it. So, what is an NG tube? An NG tube is a flexible tube inserted through the nares into the stomach for the purpose of various things: sampling gastric contents, decompressing air, blood, gas, toxins, or other gastric contents, and providing nutritional support. Various indications include things like diverticulitis to provide GI rest, gastric outlet obstruction, small bowel obstruction, near drowning events, frequent vomiting, or surgery in which you may need to decompress the stomach and reduce the risk of aspiration. Some contraindications: choanal atresia, facial or neck trauma, particularly nasal trauma or basilar skull fractures, esophageal strictures, recent surgery of the esophagus or stomach, esophageal burns, or Zenker's diverticuli. Some complications: trauma along the passageway from the nose all the way down through the stomach, possibly pneumonia if you put the tube in the wrong place, a pneumothorax, again, if you put the tube in the wrong place, gastric erosion or hemorrhaging because the suction of the NG tube is right along the gastric mucosa and it can cause some hemorrhage there, sinusitis or even just nasal irritation and pain. There is this like famous, I guess, warning sign where there was a case where somebody put an NG tube all the way into somebody's brain. I think it must have been in a trauma patient. Don't do that. The most common types of NG tube that I see are Salem sump tubes. These are dual lumen with a blue pigtail, and they're designed ideally for suction. Levin tubes are single lumen tubes used for short-term feeding or suction, and they can be inserted nasally or orally. I think the Levin is probably the most commonly used. I manage a lot of Salem sump NG tubes, particularly in my general surgery patients. There's not necessarily one right one to use. You just need to make a decision one way or another based on your patient scenario. These are measured based on the French scale. So this is how you determine the size of an NG tube. Essentially, each unit equals 0.33 millimeters in diameter. So you're measuring diameter. An 18 French NG tube is 6 millimeters in diameter. And the way you measure or why this is important is to pick the appropriate size. So for children, you're going to pick a 3 to 8 French. For adults, a 10 to 18 French. And greater than 18 French if you're doing orally for emergent suction or an emergent situation, which you can have to do at times. There is all kinds of equipment and things that you need for insertion, but essentially, in an ideal situation that I think you're going to test question about, your patient is going to be alert and able to cooperate and consent. So definitely get consent and let them know that this is unpleasant, but once it's placed, people feel much more comfortable symptom-wise. Have all of your stuff ready to go and place your patient at a 45 to 90 degree angle and assess the patency of their nares and measure the NG tube so you know how far to insert it by measuring from the tip of the nose to the earlobe to the xiphoid process. And next, wash your hands, PPE, all of that good stuff. Have a cup of water available and mark the insertion length with tape. Once everything is set up and ready to go, lubricate the first 3 inches of the tube with lidocaine jelly, and then assist the patient or ask the patient to flex their neck forward. Slowly and gently insert the tube into the nostril straight back and have the patient start to take small sips of water through a straw and swallow as you advance the tube. As the tube passes, have the patient raise their chin away from their chest, and if the patient gags, don't pull the tube out completely if you can. Just pause where you are, advise them to take some deep breaths, and see if you can get them to calm down enough to keep going. Because the last thing you want to do is rip that thing out and then have to put it back again. Try to just become very still and see if it'll pass. If you come into any obstruction, don't force the tube. Withdraw slightly and then try again. If you again meet resistance, remove it. Don't force anything. Once an NG tube is in place, you want to get a chest x-ray to confirm placement. If an x-ray is contraindicated or not readily available, you can inject 10 milliliters of air through the tube while auscultating the abdomen to see if you can detect a rush of air. But most of the time we get chest x-rays. Make sure to stabilize the NG tube and make sure that it's functioning properly. So the way that I generally use an NG tube when I'm decompressing, it should be to low continuous wall suction, meaning low all the time suction, and you want to make sure that it's functioning. So make sure that all the connections are hooked up correctly and make sure that you're monitoring the output appropriately. Usually, when you're using these in the situation I'm describing, for example, in a small bowel obstruction, you're going to measure the output quality and character. So you need to know the I's and O's of your patient. How much is coming out of the NG tube and what time frame and what is in the canister? Is it blood? Is it gastric contents? Is it bilious? These things can tell you what you might need to do as far as next steps go for the clinical management of your patient. That's kind of all I'm going to say about that. TPN. This is an interesting one. It's very brief, my notes that I put down. Essentially, this is transparental nutrition. So essentially, when you're talking about patients and diet advancement, in general surgery, we like to advance the diet with the return of bowel function. So if your patient is passing gas or having a bowel movement, they can have clears, then fulls, then regular. As long as they're tolerating all that stuff without nausea, vomiting, or new pain, then you can kind of increase to their regular diet, decrease their maintenance fluids, turn off their IV stuff, and transition everything to oral regimen. If they fail a step, you can move backwards. Why is that important? Because transparental nutrition, or as I like to call it, IV food, when I'm explaining it to patients, is super important. Patients need to have nutrition. Ideally, we want to feed the gut. I always want to give my patients real food. That's where all the data says all the good stuff comes from. You want to feed the gut when you can. That's not always possible. So, when it's not possible, we use TPN. Some of the basics that I thought were important to know were really the indications. So these are kind of specific situations. Firstly, patients who have inadequate or absent PO intake or oral intake for around 7 to 10 days. A patient who you expect to be unable to take PO intake for greater than 10 days, or a patient who has very obvious malnutrition, greater than 10% of body weight loss over 3 months. Generally speaking, I like to say if I'm reaching 5 to 7 days, I should be thinking about nutrition. Can I get my patient oral nutrition in the next 24 hours? If I do not think that that's possible, I need to consider TPN. Or if I am just confident that a patient's going to need that, then I can start it early. The basics of TPN include things like needing to have central access, consulting nutrition and dietary services, and helping them calculate the contents of TPN. TPN is going to have everything you need nutritionally, but given to your venous system essentially. So you're going to have things like protein, non-protein calories. You can put things like insulin into the bag, various electrolytes, phosphorus, magnesium, potassium. So all of these things need to be monitored, right? So if a patient is on TPN, they need to have all of this stuff checked daily. BMP, a weekly CMP, prealbumin, and usually a mag-phos because that's not on your BMP. You also just need to remember that when you're taking TPN off, we generally don't just turn it off and remove it completely. Generally, we wean it by cutting it in half and then turning it off the next day. So bear that in mind as well. Now we get into the fun stuff. I think these next couple ones are so interesting. First off is abdominal drains. I mean, maybe this isn't interesting to anyone else, but I think drains are kind of cool. They're really useful. I manage them all the time, and I think that it's not something that everybody thinks about. However, very important. There are some indications for drains. Generally speaking, that I found like two big categories as far as the GI system is considered. So one is abscess drainage slash evaluation, and then post-op monitoring. For example, patients who have recently had a cholecystectomy and it was open and nasty and really rough, you can leave a drain behind and check to see if bile comes out of the JP drain over the next several days and monitor it. If you have a patient who's recently had a major abdominal surgery that was oozy, then you can place an abdominal drain and monitor it for rebleeding. If you have a patient who's had a recent bowel perforation that you've repaired, but you're concerned that it may not hold, you could place a drain and then monitor it for the next several days to see if the drain develops feculent stuff. So poop in the drain. Essentially, these are Jackson Pratt drains or those bulb type drains. That's the most common kind. A lot of us just call them JP drains, even when they're not JP drains. There are different types, but usually they're on a bulb. When they're placed, they don't exit the surgical incision. They usually exit a different incision. And where the incision is or where the abdominal drain is exiting the abdominal wall is not necessarily where the drain opening is. It could be across the body. It could be north, south, east, or west. So it can be in various places. You're going to have to check the op note to see exactly where it is or just discuss with the team. How do you manage these? They must be to bulb suction in order for them to work. So you have to squeeze it down and press the little plunger so that there's vacuum suction applied. Overall, same concept as an NG tube. You're going to record the character and the output. Is it purulent? Is it bilious? Is it serosanguinous? Is it serous? Is it sanguinous, as in bloody? How much? How often? If it's clotted or clogged, you can strip it, and also you can flush it. When the output is low and you get more towards the serous output, that's when we like to take them out. When it's low, I guess generally around less than 50 cc's in 24 hours, sometimes even more strict than that, less than 10 cc's in 24 hours, just depending on the situation. And then you can remove the drain. One thing to note is that these abdominal drains can also be placed by interventional radiology, so you don't necessarily need to have surgery in order to utilize these drains to get what you need, because you can also send the contents of these drains for sampling and culturing. You could drain an abscess with IR, which is a minimally invasive procedure, leave a drain behind, and take that abscess and send it off to a lab, and then tailor your antibiotic therapy after that. Next up are ileostomies. I think this one is interesting. I thought this one, it fits. I guess it's a GI procedure, but I feel like this is it's a surgery. I feel like I'm describing a case, essentially. The indications for this are anytime you need to bypass the entire colon and rectum. Usually that's to protect a fresh anastomosis. However, there are times when we do a total colectomy or total removal of the colon, and all that's left is the terminal ileum. So that's it. That's what you got, and it don't reach or fit anywhere else but up top. So an ileostomy is when you bring the terminal part of the small bowel up to the surface of the abdominal wall and create a stoma, very similar to a colostomy a colostomy. And then again, you can have a bag and then it excretes stool. The procedure for this is to essentially, however you're doing this, either laparoscopically or open, you need to mobilize the bowel of interest. You need to create an aperture or an opening in the abdominal wall. You want to advance your endostomy or the terminal portion of bowel that you're using, which usually has a staple line, and then advance it through that aperture or that opening, and what we call mature it. So when we say mature it, we mean deliver the end of small bowel through the abdominal wall to the outside world, transect the staple line, and then suture it while everting the intestines in order to approximate the bowel with the dermis. And that's essentially how you create a stoma. Now, stomas in this situation can be either an end stoma or a diverting loop. Now, a diverting loop is when a loop of terminal ileum is brought out through the abdominal wall and sutured to the dermis and stabilized with a rod underneath. So there's now two openings essentially until the bowel granulates to the abdominal wall. An end stoma just has the one end of the small bowel in question. That probably makes zero sense. Look up a picture of that. That's hard to describe. Placement of your stoma is very important, so it matters where you put this. Generally, we like to say 5 centimeters away from folds, creases, other incisions, the belly button, and other bony prominences. If you are doing an elective case, then you can have somebody come in and help manipulate your patient, and you guys can plan where you want it to be. If you're doing it emergently, you can't do that, so you have to wing it. In that situation, your stoma would be 2/3 of the way along the line from the anterior superior iliac spine and umbilicus. Hear that again. 2/3 the way along the line from the anterior superior iliac spine and umbilicus. Now, an ileostomy is going to have stool output very similar to a colostomy. The output for an ileostomy, however, is going to be very different. You're going to have more output overall, and then you're also going to have more liquid stool as opposed to firmer. You're not necessarily going to have solid stool in either situation, but certainly for an ileostomy, it's going to be more liquid. The typical average output, once you have a well-healed, well-established ileostomy, generally should be between 500 to 1,300 milliliters per day of liquid stool. That stool is going to contain digestive enzymes, sodium, potassium, other electrolytes, lots of water. And Therefore, you're going to need to potentially replace all of those things. In addition, digestive enzymes can be caustic to the skin, so I'm trying to prep you for complications that I'm going to talk about in a second. Ileostomies do not have to be permanent. They could be reversed. If they are reversed, the timeline is usually 8 weeks to 3 months after whatever inciting event initiated this. Complications are what I think are probably more important, or what you're going to get most of your questions on with an ileostomy. As long as you can kind of generally imagine how you create an ileostomy and what the general purpose is, it's and what kind of output is coming out, I think you can reason through the complications pretty well. Firstly, if you have high output, think about it like high watery stool output with lots of electrolytes in it. What can happen? You can become dehydrated, which is one of the two most common problems. The next most common complication is also related to the output. I just mentioned that it has high elements of digestive enzymes. What is that? Caustic to the skin. What is your number 2 most common complication? Skin irritation. Those are your big things: skin irritation and dehydration. I separated the complications now into early and late complications. So, early on in the development of an ileostomy, and then late after it's been established. If you've had an ileostomy for less than 3 months, here are the 4 most common complications that you may encounter. 1, stoma necrosis. 2, stomal bleeding. 3, stomal retraction. And 4, mucocutaneous separation. All right, necrosis, bleeding, retraction, separation. I don't have a great way to remember these things except for the fact that everything has to do with the stoma. So monitor your stoma. Think about things that can happen to it. It could die. It could bleed. It could retract backwards into the abdomen, or the edges could separate from the skin. I think when you think about it like that, it's kind of easy to remember that everything has to do with the stoma. What are the common things that could happen? You could have a dead stoma, it could bleed, it could move, and by that I mean it could go backwards or it could separate on the sides. Now, late complications, I only put 3. I think that I would call these probably more common. Most of the time, these can be asymptomatic, as in you don't really need to do anything about them, whereas these early complications oftentimes require some type of intervention. For stomal necrosis, if it's full thickness, particularly at the fascial level, you often need to do surgical intervention. Stomal bleeding can be controlled with things like manual pressure, different hemostatic agents, but again, if you're having drastic bleeding that you suspect maybe is under the skin and you can't see it, and you have clinical indications otherwise of very dramatic bleeding, then again, that may require surgical intervention. Mucocutaneous separation also is one that can require intervention. So bear those things in mind, that these things can be complications that require you to do something. These late complications, first up is peristomal hernias. So these are hernias that are right next to the stoma. You can still have things like omentum, small bowel, colon if you still have colon, and it can be sitting in a hernia sac that develops. Again, these are usually asymptomatic. However, they can cause obstruction and again require you to do something like surgery. Stomal prolapse. This is when you have telescoping of the intestine out from the stoma. So remember when I said stomal retraction is an early complication? Stomal prolapse is a late complication. One cute little, I guess not cute, one little tidbit for management of this: table sugar or honey can sometimes help with stomal prolapse. So bear that in mind. I had a preceptor ask me about this. Stomal stenosis. This is when you can get like strictures of the stoma, particularly at the fascial level. One option is to place a Foley, but if you do that, don't inflate the balloon. Be very careful if you're going to do something like that. I would have an expert around you. Probably not going to be doing this as a student, but again, just think about things that make sense. You might want to try and dilate the space very gently and very, very carefully. Last but definitely not least, because I have a love-hate relationship with these procedures, is a PEG tube or gastrotomy tube placement using the percutaneous endoscopic method. That makes no sense, but PEG tubes are the bane and love of my existence. I think they're really cool. I think they're super important. I really struggle to drive the endoscope because I have little girl hands and I'm left-handed, so driving the endoscope is a little tough. However, I am practicing as much as I can, and I always have somebody who's very experienced right there with me. So I have been practicing a lot and I'm getting better at it. The indications for this are really simple once you know what the purpose is. So, what is this for? This is a tube that goes into the stomach. It can decompress or feed. So, think about things that may require you to need a tube that goes into your stomach that does not go through your mouth, it goes through your abdominal wall that helps you because you can't eat through your mouth or because you need to be decompressed due to some reason. Common indications for PEG procedures, now that you've thought about that, think about it. Okay, first up, dysphagia. If you have difficulty swallowing and you have a high aspiration risk and you can't really do anything about it, then a tube that goes directly into your stomach eliminates the problem of nutrition. Perhaps you'll have to chew and spit, but there you go. Another example, very similarly along that way, is head or neck cancer. If you have head or neck cancer and you can't swallow because of the compression in your esophagus, then bypass the esophagus and put a tube right into your stomach. This next one is interesting, palliative decompression. For these patients, a gastrostomy tube is helpful to when you have possible gastric outlet obstruction or compression on the stomach. Basically, think about GI malignancies that could compress or obstruct the stomach. And then, therefore, you want a tube to allow you to empty the stomach that way. You could provide a feeding tube somewhere else, even if you were only trying to decompress, if that makes sense. So, there is a world in which you do a palliative decompression and then you create another feeding access. Most commonly that I see this used are patients who are in a persistent vegetative state or who have a prolonged course, like a prolonged trach wean coming their way, and you want to provide feeding access and you think it'll take a long time for them to obtain it orally. In those situations, a PEG tube might be a great option. We often do a trach peg at the same time and do them together because both procedures require two operators to be done. Well, in the push-pull method, which I'm going to talk about in a second. Now, like I said, this is a tube that goes into the stomach. There is a obviously opening at the abdominal wall and the tube exits. There is an external bumper that keeps it flush to the skin, and that'll be important later. And then you can connect it to feeds or you can leave it to gravity and allow it to decompress. How do you place a PEG tube? I'm going to go very briefly overview. Nobody get mad at me for skipping over some of the details. The procedure for a PEG tube that I think is most important is the push and pull method. You can also do this radiographically with interventional radiology, and you can also do this surgically either by laparoscope or open. That being said, push and pull method requires two people. You first need to do an upper endoscopy. The endoscope can actually put out a light at the tip. So once you get into the stomach, you insufflate or push air through to expand the stomach and bring it closer to the anterior abdominal wall. Then you can turn the light on, and the light trans-illuminates through the abdominal wall to the outside world where your second person is looking to see. Once you have decided on your spot, you can anesthetize at the skin level, and you're going to insert your introducer needle. Once you do that, you can feed a wire through the EGD, so through the scope, down into the stomach, and it has a snare on the bottom, so it opens up to be a little loop. Once that loop is open, through the introducer, your second person is putting a wire through the introducer to be caught by the snare. Now, person one removes the wire and the endoscope at the same time. So now you have a wire coming out of the patient's mouth. You attach the tube there, and then your person number two, who's at the belly side, pulls the wire back. Get it? Push, pull. Pulls the wire back with the endoscope and snare in place and the PEG tube, and then can pull it through the skin incision that you've made. And then your internal bolster is in place on the inside of the stomach, and your external bolster is in place on the outside because you slide it on. kind of confusing, look up a YouTube video, find a cute little quick animation video, even just something to help you visualize it. Because I think once you visualize it, it makes sense, the complications, which is, again, I think what you're going to get a lot of questions about. Now, when do you use a new peg tube? Generally, people say you can have meds after 4 hours, tube feeds after 24 hours. So, generally. One tidbit as far as care, there is an external bolster that should be flush to the skin. If you are going to put gauze pads around this, it has to go above, not under, because you're going to create tension on the tract. Eventually, as a patient has a peg tube for a long time, a tract will form from the stomach to the skin, kind of stented open by the tube. So bear that in mind as well. So if you ever need to replace a peg tube, as long as it's a well-established one, you could just slide something right back in. Important for later. Now, a couple complications. Think about the simple stuff: tube dysfunction, skin infection, bleeding, and early removal or dislodgement. So you can have dysfunction of the tube itself, skin irritation, bleeding, it's always bleeding, or dislodgement of the tube. Generally, if you're having bleeding post-procedure, it can be rare to have severe bleeding, but also deadly. So you can't just write it off. You can have bleeding at the skin level or deeper. So if you have bleeding right at the skin edge and it's just oozing and it's not too bad, generally you're good. However, if you have signs of severe bleeding, H&H dropping, signs of hemodynamic instability, if you can aspirate frank blood, that is a problem, and you're going to need to do something about that, including probably transfuse blood. So, like I said, this can be rare but deadly. The big scary one would be perforating the gastric artery or the SMA. So those would be big scary things that are very rare but can happen and does happen. And you can also have smaller bleeds at the skin edges. For those skin level bleeders, you can do manual pressure or place a hemostatic agent or even a suture. And then for those signs of severe bleeding, you obviously need to identify the source of the bleeding as quickly as you can while also stabilizing the patient, generally through a blood transfusion. If you have signs of bleeding, what do you give? Blood. Not fluid, blood. Now, if you have a peg tube that gets dislodged, fingers crossed it is a well-established peg tube, because then you can do something simple like place a Foley or a replacement peg tube pretty easily. If it is early in the peg tube placement, you may need to get some imaging and possibly upgrade to having the interventional radiology team help out or doing something surgical to replace it. Finally, the one complication I wanted to mention before we finish this very long episode is the idea that your peg tube can be dislodged both on the entirely, completely removed, and also just slipped out of the stomach or dislodged in some other fashion intra-abdominally, and you won't notice. Therefore, you could be feeding a tube that is in the wrong spot. That could mean tube feeds could end up in the abdominal cavity. It could end up in the subcutaneous tissue. It can cause all kinds of problems. If you're leaking tube feeds into the wrong spot, what's probably going to happen? Bad things. Sepsis, infection, abscess development, possibly even, necrosis of tissue surrounding. Those things can all be very bad. So don't take it lightly if you have a patient who develops peritonitis and they've had a peg tube placed, particularly recently, because I think those are a little bit more likely to get dislodged. And by that I mean even in like the last 6 months, I would consider that relatively recently as far as dislodgement goes. Those things can be quite severe. I think that overall these procedures are straightforward as long as you know what they are and they make sense. So don't be afraid to just Google a video or Google a picture so that you actually know what I'm talking about, because it's hard to describe things. Once you know what it is, you can identify it. You can come up with complications pretty easily, I think. The things that I think you're going to get questions on are the obvious indications, the obvious contraindications, and the obvious complications. I think that for somebody who's going to be doing a surgery rotation or who's going to be taking this EOR, I should give you a brief overview of the procedure, but do I think you're going to get asked the specifics of how you place an NG tube and the angle that their head should be? Honestly, no. But do I think that you should generally know how to put an NG tube in and that it's important you put it in the right spot so you don't put it in the lungs or the head? Yes, I do. Think about that when you're going through your studying and create some fun notes for yourself with pictures and videos if needed. I am going to finish this episode here right at 40 minutes. And I will talk to you guys later this week. I am so excited because I have some guests coming up and they are going to be super duper fun episodes with different specialties. So stay tuned for that. It's going to be super fun. Thanks for sticking around for these academic ones. It's really fun to make, even though it really stresses me out a little bit putting these together. And have a good night.